So, good evening, all, for one more episode of GURUKUL PATHSHALA. And it is very near and dear to the heart of each and every one of us. So, for today's episode, we are having again the OSCE. And today, the OSCE is on neonatology. For this episode, I welcome our President, Dr. Jhankhana Sanghavi Madam, for her welcome address.
Thank you, Dr. Nehal. Good evening and happy Janmashtami to everyone. I welcome respected Dr. Baldev Prajapati sir, all seniors for presence here. I welcome Honorary Secretary Gujarat Dr. Nehal Patel. I welcome Coordinator Dr. Lata. I welcome each and every seniors and respected seniors. What a day today. Today is a Hanuman Jayanti, and if students attend every OSCE punctually whole the year, then हनुमान जयंती जैसा जंप लगाएंगे और एग्जाम का दरिया पार कर देंगे. So this is what a day, the OSCE and Hanuman Jayanti. And it's not only for the students, it's for the practitioners also. If they attend OSCE particularly, understand it perfectly, then they will also jump the practice whole the year, and they revise the Nelson within a 1 year. So it's an excellent program. And if the SK is with Dr. Baldev Prajapati sir, then it's 100% the Hanuman jump for the knowledge. So everyone are welcome for this OSCE, and over to Dr. Nehal, please.
Thank you, madam. Thank you so much. And what a wonderful concept. एक दरिया लांग के जाना है, हनुमान जैसा छलांग लगाना है. And with the OSCE help of and teaching of our Baldev sir, who is mentor, as there as a Ram. So I know all our Hanuman will definitely succeed. We are missing today. We are missing today our chief coordinator and who brought the e-Gurukul in all our mind and concept of the e-Gurukul, Dr. Yogesh Parikh sir. In his absentia, he could not join today because of the other prior commitment. So with this, I am forwarding the platform to Lata. Please.
Good evening, everyone. I'm so privileged to be here. Every time I'm there to see all the OSCE and also OSCE is like Sanjeevni to all of you. So without wasting much of the time, I'll just hand over everything to Baldev sir. Sir, if you face any problem, just convey. I'll just do it quickly.
Yeah. Good evening, friends. Thank you very much for this, I will say, kind words regarding this pattern of the discussion, OSCE, and comparing it with the Hanuman and Ram and so many stories. Ultimately, all of us know that OSCE is one of the best methods for assessment as well as even the learning. And as Dr. Jhankhana and all the faculties say, not only I will say to overcome the exam, but even so many points pertaining to the practice also we can incorporate, and it is going to be even applicable in the practice also. I'm sure, and therefore I tell the student that you should be ready very fast, remain with me. As the question comes, I will say respond so that we can go for the maximum coverage of the topics on neonatology. Let me start with sharing. First, I share my PPT. Is it seen on the screen?
Yes, sir.
Yes,
It just started.
Yes, sir. And is it full screen, right?
Yes.
Okay.
Yes, sir.
So today we'll take the topic of neonatology. As I think last time also, as Dr. Lata and others did, you can just watch the responses so that we can have the interactive sessions.
Sure, sir.
This is again book which I would recommend to the postgraduate students, also even the practitioners, those who are interested to go through it. Let me start from very simple. And in the exam, it's not necessary that always some complex or difficult questions are going to be there. On the contrary, they wish that very common topic should be included. Here, mother noticed a swelling over the scalp in 2 days old infant as shown in the picture. You can see, and then I will go for the questions. The first question, what is your diagnosis, spot diagnosis from appearance of the swelling? Yes. I think even those students on the screen, even they can respond directly, or you can put your answer on the chat box.
So they have started giving answers.
Yeah, Lata, because I will not be able to check it, you can help me.
Yeah, that's why I told, sir.
Yeah.
Cephalometoma is the answer coming.
Okay.
Caput, some 3 persons have answered caput.
Yeah, which was expected. So I think, let me go to the answer. It is you can see that the swelling is over the right side parietal, and that is the cephalometoma. Purposefully 2-3 clues are given. Number one, this has been appeared after 2 days. That is very common that in the Viva even, examiner is going to ask you to differentiate this cephalometoma and caput succeedum. Caput succeedum, we know that it is only mainly on the presenting part when the vertex presentation, and that will be present at the time of birth. On the contrary, within 24-48 hours, it may disappear. And cephalometoma will start to appear on the second or third day. I think so many other points are there. Probably I might have put on the question that how even we can differentiate these two. But to understand it, what is the cause for this parietal or any even occipital also, cephalometoma? How it happens so? What is the reason for this development of this cephalometoma?
Somebody has answered subperiosteal bleed.
Okay. And what happens in caput? Caput, there is the collection of the fluid in the skull. Here, collection of blood in the subperiosteum. And very rightly said, it is due to the subperiosteal hemorrhage. And what are its clinical characteristics which you can differentiate from the caput? What are the clinical characteristics of this cephalometoma?
Somebody has answered firm swelling.
Yes.
Subperiosteal collection of blood doesn't cross suture.
Right.
Not crossing suture, doesn't cross midline.
Right. Not the midline. Okay. Yeah.
And prolonged jaundice.
Yeah. I think in the OSCE, please remember, the question should be, answer should be very precise. And if it is not, I will say, very precise answer, you may not get the mark. Here, let me put the answer. The swelling appears after few hours to days. Usually, I will say on second or third day. Because subperiosteal bleeding is a slow process. And very important point, it does not cross the suture line. Further, initially it is going to be soft. Later on, it may become firm, even hard in consistency because with the calcification. And it may disappear. It may take sometimes even months together to disappear. So these are the main characteristics which we can keep in mind. Even the practice also, such type of the patients are referred to us, or even parents will ask all these questions when the swelling is there over the scalp. What is its usual course? What happens to this subperiosteal hemorrhage or bleeding for the cephalometoma? What happens to this? What is its fate? What is its course?
Get resolved on its own calcification.
Yeah. Is there a duration?
2 to 3 weeks.
Okay. Please remember, most of the cephalomatomas are reabsorbed, organized within 2 weeks to 3 months' time. Please remember, sometimes they come late. We have answered that in a month or so it will disappear, but then the parents will come back that now 2 months, but still it is there. But if you have seen, from soft to firm to hard in consistency and size is decreasing, and somebody has suppose taken the X-ray or sonography, it may be appeared the calcified and it is going to disappear. So it is not going to create any trouble. But the next question is, what is the treatment of this cephalometoma? Parents have come to you for the treatment. So what treatment we will offer? What treatment?
Reassurance. Dr.
Right?
Kriti has answered. Reassurance. 2 persons. Dr. Deepa also answered reassurance.
I think Dr. Preeti, our faculty.
Kriti, I don't know, sir. Kriti
Why? Because then naturally she will be able to answer every question.
Oh.
Anyway, it's a good thing. If somebody is interested,
Kriti, ma'am.
it's good.
Okay.
Anyway,
Is
but
NH phototherapy?
I
Somebody
will encourage even the responses. Okay. Usually treatment point of view, no treatment is required. Please, this is very important. Don't do. Sometimes, the treatment inactivity is very important. Your action will create the problem. Of course, that point is right. There's a part or complication. Suppose something develops, that you will have to manage. It's a different story. But otherwise, it does not require any active treatment. What are its known complications? Now the supposed complications, and these are the expected, which you should be very watchful. And by chance, if it develops, you have to act. Otherwise, don't do anything. What are the complications? Already, I think, enumerated, many mentioned already.
Yes, neonatal hyperbilirubinemia.
Yes,
infection,
it is there.
Jaundice,
Right.
hemolysis, anemia.
Very good. Good points. I will say most of the points included. Hyperbilirubinemia, we should be careful, which may require the phototherapy. And rightly say that suppose by chance we get infected, may require that, I will say some intervention. But infection, usually if somebody has tried aspiration, it's a iatrogenic problem. And therefore, many a times, I think nowadays it does not happen so, but in the past I have seen that some of the surgeons, general practitioner, they put the needle and try to aspirate, and then really abscess or the infection develops and the real story of complication starts. So here I think it's very common condition in our daily practice. And even why the OSCE is prepared in this way, because I'm one of the trainers for the OSCE preparing, that what are the questions you should formulate. In the National DNB office, I visit even occasionally whenever this type of workshop, that the question, even for teachers also, it is very important that the question should be very clear. There should not be ambiguity in the meaning of the question. Question should be very precise. And don't ask the question with some range, because then anything even may be the correct answer. So I think this is the beauty of this OSCE, and even in the practice, that how precisely we can answer to the parents. Anyway, let us move to the, and CAPAT, I think that is very important to be differentiated. CAPAT will be usually at the time of, because it's a presenting part, commonly vertex, at the time of birth it is present. If even somebody had done the vacuum, it may be one scalp might have been separated. Usually, CAPAT is the collection of fluid. It will cross even the suture line. The suture line will not be crossed by the cephalometoma, and swelling will usually try to decrease in 24-40 hours. Many times it will disappear in a case of CAPAT. So that's the thing that how we can differentiate. Anyway, let us come to this even another common situation. Regarding the antenatal corticosteroids in the preterm labor, when you are expecting, then some of the questions they are going to put. What are the indications? That means in which situation you will go for the antenatal corticosteroids. Yes, Lata, anybody?
P-prom. Yes, sir, just now. P-prom. Preterm delivery, less than 34 weeks, prom. Then between 24 to 34 weeks, GA if delivery is expected.
Okay.
This much only. I'm waiting for it.
Again, if I remind you, answers should be very precise. Something, if you say it is not going to be wrong, but it does not mean that it is going to be considered right. So please, exact indication that the risk of preterm delivery between 24 and 34 weeks of gestation. This is the recent recommendation. Even simply, I will recommend to the students that please go through the OP guide. This is really very compact book, and impact is very good even for the routine conditions. So risk of the preterm delivery when you are predicting between 24 and 34 weeks of gestation. Then the next question, what is the optimal timing? What is the optimal timing? That means when you should give. Until what time the effect may be available. That is the optimal timing. Yes, Lata, any response?
No, sir. Last dose at least 24 hours prior to delivery, before 24 hours, at least 48 hours prior to birth, and less than 28 weeks. Then 24 hours before delivery. Last 2 days before.
Right.
This much has been answered.
So the correct answer is, it is beneficial if delivery occurs after 24 to 48 hours of your antenatal steroids. And effect lasts for 7 days. Sometimes suppose 7 days already passed, even the dose can be repeated. If it is really expected the preterm, which is going to be difficult, it can be repeated. Sometimes even in the term baby also, suppose it is due to some reason expecting some neonatology give. But I think for our exam point of view, mention in this way, this is the optimal timing. Then third question is going to be there, what doses? Even which preparation? Which preparation, which doses?
So waiting for the answer.
Yeah, I am also waiting.
Different for DEXA and beta. Betamethasone 12 milligrams, 12 hours apart for 2 doses.
Okay.
Betamethasone 12 milligram BD.
Right.
From Dr. Sam has answered. Then dexamethasone 6 milligrams 6 hourly apart for 4 doses.
Right.
Betamethasone 2 doses. Dexamethasone 6 milligram BD 12 hours 4 doses. Dexa 6 milligram 4 doses.
I think individual answer is not complete, but if I consider these all the responses, ultimately correct answer is there. And the correct answer, betamethasone injection 12 milligram intramuscular every 24 hours and 2 doses. Dexamethasone 6 milligram intramuscular, that is every 12 hours and total 4 doses. So duration, if you see, it remains almost 48 hours. But betamethasone 2 doses, dexamethasone 4 doses are different, 12 and 6, interval is different. But my question is going to be different. Which preparation is preferred among these two? And which one and why? Among these two, so about both preparations, somebody say that what will be your choice? Yes?
4 persons have answered betamethasone.
Right.
And last one has Dr. Raghavendra has answered DEXA is widely available.
Yeah.
Then Dr. Yadagiri Billa has said betamethasone.
Okay. I think in a lighter tone, if I say, probably beta-methadone response is probably from old persons like me, and dexamethasone is, I will say, response from some young person. And correct answer is dexamethasone. Particularly, it is said that in the developing countries or low resource countries, dexamethasone is preferred. Reason is readily available and less expensive. Somebody rightly responded. I think in the past we were taught that beta-methasone is better than the dexamethasone. And the explanation was something different during that time. That beta-methasone is having the very specific affinity for these receptors which are useful for surfactant synthesis. That was the explanation which was offered to us in the past. Probably my MD, suppose somebody has asked, I must have responded beta-methasone. But now the people say that action point of view, both are equal. There is no any superiority of beta or dexa. And availability and even expense point of view, the dexamethasone is commonly preferred nowadays, and it is there in the practice. So I think that we'll have to remember which is the change compared to the past. Somebody, I think all the questions difficult to include, but somebody may ask even some other question, that what other complications can be prevented by the anterior corticosteroids? Or which problems or complications can be prevented by offering anterior corticosteroids in preterm labor?
RDS,
Okay,
RDS,
right.
HMD, RDS, IVH, NEC.
I think here one should be very clear. RDS is a vague answer. Respiratory distress syndrome can be due to pneumonia, can be even due to pleural effusion, or even any malformation. So that is respiratory syndrome. But for the preterm, if you are answering hyaline membrane disease, is the correct answer. Okay. Anything else besides the hyaline membrane disease?
Yes, sir. IVH, intraventricular hemorrhage.
Yes, right.
Then NEC.
Yes.
Then BPD.
Okay.
ROP.
Okay. Please don't enumerate all the complications of the preterm. That is very common answer, and that's why this type of the question are going to be asked in I think I have formed these questions, which I may include even more, and they are here. At present, I think all these even complications in the past it was considered, but now they are very clear. ROP is the part of the complication of preterm. It is not directly related to the steroids. So there is no question of that. NEC was considered in the past, but now the people have confirmed that hardly makes any difference in the NEC development as a complication. So mainly two at present considered correct answers, complications which can be prevented by the antisteroids. Number one is the hyaline membrane disease, and number two is the intraventricular hemorrhage. These two complications, definitely we are getting the benefits from anterior corticosteroids. So please remember, anyway, let us go further. The findings on ophthalmic examination of the newborn, they are in the form of the A, B, and C. You can look at the picture. What is the difference? Even I have made this, which one is normal and which one is affected. The only thing that in what way affected, that we'll have to find out. Here I think, okay, let me go for the question, then we'll go for some comments. I hope that everybody has seen the picture. What is the name of this test? What is the name of this test? This test is having very specific name.
Red reflex.
Okay.
Pupillary reflex. Two
Yes.
answers of red reflex and one is pupillary reflex.
Please, pupillary reflex is not going to get the correct answer in the OSCE. But yes, it is the red reflex test. What I want to, purposefully this OSCE, another thing why we want to keep this OSCE. We want to emphasize that every consultant, neonatologist or general pediatrician who is attending the newborn should go for this routine examination. And that is the red reflex test. Now, if it is something normal, there's some problem, that let us see. I have put the three pictures, A, B, and C. If I show you the picture, these are the A, B, and C. My question is going to be, which are normal, which are abnormal, and what is the abnormality? That means, what does it indicate? From A, B, and C. At least
Dr.
group,
Yadagiri has said that
yes.
C is white. C white reflex.
Hmm.
Somebody has said, Dr. Sam, leukocoria.
Yes. Very good.
Dr. Bhavika, A normal, C white reflex.
Hmm.
Dr. Raghavendra, A normal, B incomplete, C white reflex.
Perfect. Perfect. Very good. I did different responses, but ultimately answer is there. You know, A is the symmetrical reflex. That means normal. B, if you see, is a normal in one eye. That is, I will say, left-hand side, but diminished in another eye. It is diminished, not totally absent. And that maybe people say that various malformations, even refractive error, somebody has answered even in the book. But in short, it is affected. And C is very classically in another eye, that is the right-hand side, right eye, it is absent. And that is the very rightly somebody has answered. That it is the indicating the white reflex. And that is most common in the retinoplasty. And not to miss it, please just I will put the next question and then I will have to answer the. Please look at this picture. નરેન્દ્ર ભાઈ, સોરી મેં તમને મોડા ફોન કર્યો હતો હમણાં ટીચિંગમાં હતો. કાલે સવારે 8 વાગે કલેક્શન માટે મોકલશો મારી ડોટર માટે? એ મારા ઘરે જ અહીંયા નારણપુરા સરદારમાં પ્લીઝ પ્લીઝ. હા થેન્ક યુ થેન્ક યુ થેન્ક યુ.
The answers have come.
Yes, I think you can.
Mileria, by Dr. Kriti Yadagiri, Mohan Raj, Dr.
Yeah.
Devendra answered milia. Dr. Devendra normal milia, Dr. Deepa milia, Dr. Lakshmi milia, Dr. Sam milia which is normal.
Okay. I think purposefully I have kept very simple asking the first session. I thought that the second session at another time, when you will get the opportunity, will go some complicated. But you know, routinely I have seen, even in the OSCE DNB exams, that they are asking most of the times routine conditions. Hardly they will go for some complicated. And therefore I have prepared the first OSCE in neonatology, very basic. Question is the condition. Yes, it is the answer. It is milia. Please remember, it is not malaria. It is milia. If malaria, that comes to the, I will say, different types. Miliaria cristalaria, Miliaria rubra, Miliaria pustularis. That is miliaria. M-I-L-I-R-I-A. Miliaria rubra means prickly heat. Miliaria cristalaria, that is very crystal clear fluid. That may be any condition with a high-grade fever. Even in older children, you can see. More so with the enteric fever. And if it gets infected, it is Miliaria pustularis. So that Miliaria rubra, Miliaria cristalaria, and Miliaria pustularis is different. That also I answer. And in this patient, in newborn, this is milia. That is called milia neonatorum. But the next question, which structure of the skin is involved in this disorder? Which structure is responsible for this manifestation in the newborn?
Sebaceous gland, Dr. Kriti has answered.
Okay.
Corneum, Dr. Sam has answered.
Right.
Dr. Yadagiri has answered sweat glands.
Yes.
Dr. Devendra, sebaceous glands.
Okay.
Dr. Chaitanya, sebaceous gland. Raghavendra, zona glomerularis. Dr. Deepa, sebaceous glands. Dr. Yogesh, sweat glands, sebaceous.
Fine. I think that's good that multiple responses are available. I will request them that why they are not coming on the screen. Directly they can interact, they can answer. Lata? You can request all the students that becomes, I will say, still live. You can yes answer. And I will say very good responses are there. Please remember, the correct answer is sebaceous gland. It's not the sweat gland. It's a sebaceous gland. And punctum is closed. The sebaceous gland opening is there. That opening is blocked by that punctum is blocked by the sebum. And therefore there is collection, which is appearing over this area, over the face and surrounding the nose. So that is very common situation. And sebaceous gland are maximum located over this part. And sweat glands are maximum located over the scalp. And therefore, in any condition, there is a sweating over the scalp. So that is the even anatomical point also we can remember. What treatment will you suggest now? Because mother has come for the treatment. Which antibiotic?
No treatment, sir. No treatment, Dr. Kriti. Reassurance. Dr. Chaitanya, reassurance. Yeah,
very good. Very good. Very good. I think, yes, come on. Yes. There should be some strong voice. Good, yeah. I appreciate. Absolutely, no treatment is required. Just keep it clean. It is going to subside by its own. Even somebody may ask the question, which I have not put over here, that why there is excessive secretion in the newborn? Why there is an excessive secretion of the sebum from the sebaceous glands in the newborn?
Someone try to answer. Please be on screen. Maternal hormone, somebody has answered. Estrogen levels more. Maternal hormone, maternal hormonal effects.
Absolutely. I think you can go to the adolescents. Adolescents develop acne, and it is having the link with this. Here, I think maternal hormone, very right answer, particularly the estrogen preparation. That is reflected in the newborn, and therefore this is a transient condition. As the maternal hormones go down, this is going to disappear. Therefore, no treatment, just reassurance that, okay, it is normal phenomena. Don't worry, it will not create any problem and it is going to subside. Counsel the mother. Usually somebody asks, how much time? Most of the times, 2 to 3 weeks. Then my question, I think here it is not put, that sometimes the questions will come spontaneously. If maternal hormone is reflected in the newborn, what are the other situations which are the, I will say, reflection of the maternal hormone in the newborn? Can you give some other illustrations or examples? Which is
vaginal bleeding.
Okay.
Yeah, good answer. I'll just stop.
Vaginal bleed, sir.
Yes, very good. Anything else?
The same response is coming.
This is one, but there are multiple, 2, 3.
Enlarged breast, sir.
Enlarged breast, yes. Absolutely. Right. And you see still more? I think in the suppose if I'm taking the Viva in the exam, I will show in the newborn, I will show the structure to the candidate and then I will say that, do you find this different in the newborn? And then why this difference and what is the reason? Yes, Lata, you said something?
Yes, sir. Few people have answered milk secretion.
Okay.
And mastitis neonatorum, PV bleed, this much, sir. Extra answers.
What happens in the male child? Let me come to I'm giving some clue. What happens in the male child? Except probably enlarged breast. Anything else?
And Dr. Vishwa has answered clitoris is enlarged.
In the male child I'm talking. In the male child there is a
scrotal swelling, sir.
Scrotal swelling, yes. What happens to the scrotal swelling? Is there swelling or something else? At least that means I know that he or she knows, but probably does not know correct how to express.
Sir, Dr. Jagadisha has answered hyperpigmented genitalia. Dr. Lokesh has answered smegma with scrotomegaly. Dr. Dev has answered hydrocele. Dr. Sam has
Okay.
said labia fusion.
Okay, and let me answer. All these answers are not correct.
Mm.
That means something else, something else. Number one, hydrocele is not due to any hormone.
Hydros.
It's a malformation.
Mm.
It's again the gravitation of the fluid in the tunica vaginalis. It may disappear again after 6 months to 1 year. If it is free, it may not require, unless it is encysted hydrocele, which will require the surgery. I think I will answer some other questions because people are going to ask in the Viva. Even in our practice also, parents are coming. Second thing, smegma again is not due to that. In the scrotum, what happens, if you have seen, hyperpigmentation is not the answer. Hyperpigmentation, then you may think something congenital hyperplasia, if it is really true hyperpigmentation. But if you have seen that the scrotum is larger and loose, in the newborn, scrotum is larger and newborns, and it is said it's an analog of the labia of the female. And due to the estrogenic effect of the maternal hormone, this scrotum is comparatively in the newborn, it is larger, it is loose, and as the effect goes away, if you see that it becomes a very good sac, it does not sac down. And that is many a times I will say, suppose the performance is good of the candidate, somebody asks the question. Anyway, let us go further. That's why I'm telling you, I think this OSCE should answer not 100,000 questions. I think 2 hours, I should be able to cover roughly, I will say, some hundreds of the questions on the topic. Yes, I think what are these retention cysts called when they present in the midline palate? Somebody may show you in the exam. It is similar to that.
Epstein pulse.
Very good, very good, very good. Absolutely, Epstein pulse. And somebody may ask you, or even, another OSCE, I will keep you in the Epstein pulse picture and then frame the questions. Okay, fine. Let us move further. I think here, if you see, a neonate exclusively breastfed was brought with the complaints of not taking breastfeeding adequately. And you can see this is the oral lesion. I'm sure that it will be clear. Now let me put the questions. Name the condition.
Oral candidiasis.
Okay, very good.
So, 5-6 people have responded. Oral thrush, oral candidiasis, thrush.
Perfect. So I will not take much time. It's an oral thrush or oral candidiasis, but all the questions will not be so simple. What is the most common organism responsible for this infection?
Candida albicans.
Candida albicans, very good. Let me go further. Which drug is recommended for local application for this kind? Very common. I ask you. Yes, nystatin. I think nystatin we were prescribing in the past, but now some better antifungal are available for local application. And I'm sure that you must be prescribing daily this one. What
So
you are
I've got
prescribing?
answers.
Yes.
Sorry, sir.
Sorry, Lata. What is the answer?
Clotrimazole, somebody has answered.
Yes.
Maximum persons have answered clotrimazole. Some people have answered nystatin. And somebody, Dr. Shilpa, has said paint.
Sorry?
Paint. Just paint.
Okay.
I think clotrimazole paint, she means.
Clotrimazole mouth paint.
It's a clotrimazole mouth paint. It's a clotrimazole, what we are using. I think what we are using, that Candida mouth paint, what the by trade name is available, which is commonly we are prescribed. I think now nystatin it was in the past. Now, because this is safe and even the good preparation, so commonly we are, even when we were resident, this or nothing was available, we are applying junction violet. But now don't answer the junction violet. Which are the two commonly used for prophylaxis to prevent invasive infection due to this organism in inactive and extremely preterm babies? In extremely preterm babies, even usually prophylaxis we don't recommend. But here, yes, to prevent this invasive infection, not the, I will say, oral thrush. Because invasive, this infection, Candida albicans, in the extremely preterm baby will be the fatal. Therefore, which drugs are recommended?
Injection fluconazole, 6 milligram per kg, 72 hourly. Dr. Jagadisha has answered.
Right.
Dr. Kriti madam has answered injectable fluconazole. Then amphotericin B. Then avoid long-term antibiotics unnecessarily. Then fluconazole 3 milligram per kg. Dr. Deepa has answered. Dr.
Very
Bhavika
good.
has answered injection fluconazole 6 milligram per kg twice a
Right.
week.
Fine, fine. I think most of the answers are there.
Hmm.
The fluconazole is, in short, this is the commonly used antifungal in these patients. And even amphotericin B may be due to some reason, early developed, very extreme preterm, because amphotericin B now, as far as possible, we avoid, but yes, in severe infections, we may use it. What is the most common source of infection in these newborns? I'm talking of the oral thrush and other not extreme preterm babies. What is that source?
Dr. Yadagiri has said breast. Dr. Jagadisha, maternal. Then Dr. Lokesh, skin contact. Dr.
Right.
Rajiv Pidoshi, IV line.
Yeah, very good. I think honest person to mention the IV line. Commonly it is a maternal and a vaginal infection. Of course, I think somebody has answered by the breastfeeding also. If the proper hygiene care is not taken, that is also correct answer. And which infection should be ruled out? I think it not rules, but should be ruled out in the baby with a disseminated this infection. Maybe in older children. But I'm not talking of newborn. But when the dissemination...
So HIV has been answered by
very
7
good,
people.
Very good, very good. So please remember HIV. On the contrary, not responding even the oral thrush in older children, sometimes even the adults, please never miss the HIV. Very good. Anyway, let us move further. A 60-year-old Tom, neonatal brought with a severe jaundice. He was born by normal vaginal delivery at home, and his birth weight was 2.950 kg. Mother's blood group was O negative. Baby is B positive. The baby was lethargic and not taking feed. This is the scenario. That is the information available to us. I will put the questions based on this information. What is your diagnosis? What happened to the baby? I hope you have seen, you have read it perfectly. That baby was lethargic and not taking feeds. So what happened to the baby?
Sir, connectedness, late onset sepsis, pathological jaundice, AVO incompatibility, hemorrhagic jaundice, jaundice due to RH incompatibility, encephalopathy, RH incompatible pathological jaundice leading to mind. It's bilirubin-induced neutral jaundice.
Yeah. What is your diagnosis? That means impression, clinical impression from the baby's condition. So correct answer should be bilirubin encephalopathy. It's an acute bilirubin encephalopathy. Please, I would like to remind you, better not to use the term connecterus. Loosely, yes, we can say. But you must be knowing bilirubin encephalopathy, there is the different stages. So unless you have the very specific scenario, and therefore somebody may ask, even in suppose the Viva, anybody can say what is the first, I will say, to detect bilirubin encephalopathy, to detect earliest, how you can detect it? Is there any test from which you can detect the bilirubin encephalopathy earliest? Or is there any, what I mean to say, scenario? What are the points from which you can say that this baby is developing encephalopathy due to bilirubin?
Still cry, Dr. Rajiv.
Yes. It
Dr.
will be,
Rajiv will answer.
let me answer, it will be too late. Shrill cry is too late. It is going to be there, but it's too late. I want earliest.
Irritability, altered behavior, lethargy.
Again, these are the late manifestations. And therefore, I think purposefully I asked the question. Then as an examiner, I will feel that, yes, I'm the right person to ask the question. I framed the question very appropriately. Examiners should also learn how to frame the question. Please don't confuse the candidate. Please don't create the problem for the candidate. On the contrary, assess the candidate that how much that student knows the subject. Our job is not to create the problem for him. Our job is to find out how much he knows the subject. And therefore, I will say all these answers. Therefore, if I repeat the question, what is the earliest, I will say, modality? Let me use the term modality to detect bilirubin encephalopathy earliest, which will guide me for the action very promptly. I will not waste the time. If I waste, then all the manifestations, what you enumerate is going to develop. But before that, I should take the action so that I can prevent the damage to the baby.
Sorry, sir. Sir, few persons have answered hypotonia, hypertonia, sleep change, absent Moro's reflex, EEG.
Please.
Score.
All these are the late manifestations. Yes, everything is going to develop. What you enumerate is right, but it's late, early.
The madam has answered exaggerated startle response.
Sorry?
Somebody has exaggerated startle response.
Again,
and bind score. Bind score. Somebody has answered.
Okay. So let me answer now.
High-pitched cry.
Yeah. Again, that high-pitched cry is going to develop once the damage has taken place. I want to treat the baby before any damage is taken. Please remember another thing. Bilirubin encephalopathy, if detected earliest, it is reversible. At some stage, it becomes irreversible. And then all the manifestations will develop, ultimately connected, as you know, with all the extrapyramidal systems and ultimately results in the choreoathletic cerebral palsy, what we discussed. But we want early. And for that reason, it is said in the good nursery, good NICU, when you know the situation set up, some incompatibility, some borderline bilirubin level, maturity or asphyxia, some factor, where you know that it can enhance this problem of the encephalopathy. In this situation, you can monitor it and go for the constant monitoring, this Bera test. You know that earliest damage in the bilirubin encephalopathy is due to hearing. The first, which is very sensitive. And therefore, you can monitor even this Bera. And when there is an alteration of the Bera, don't wait. Go for the exchange one. Suppose if it is indicated according to your level. And that's the correct answer. Of course, then the stages are there. The first stage, change in the activity, excessive crying or sleepiness or not taking feeds, that will be the, still probably some of the babies, you can prevent this damage. Maybe the reversible, not sure. Second phase will be, I will say yes, in the form of this spasticity or shrill cry, keeping the limbs tight, all the manifestations. Third is totally connectedness. And then it is irreversible. Nothing is going, you are going to, whatever you do, is not. And nowadays, please remember, patient is with you, suppose, and a baby develops the bilirubin encephalopathy, in the court of law, we are punishable. Therefore, it is very, very important. If the baby is under your care and develops this bilirubin encephalopathy, then we are really in difficulty. Anyway, what are the sequelae? Probably already we have discussed. And connectedness is the conditions with chronic sequelae following bilirubin encephalopathy. It's a chronic sequelae now, and it is irreversible. And then we know the sequelae, cerebral palsy, or that may be the choreoathletic variety, Sensorial deafness is where even upward gaze paralysis, dental even animal dysplasia, all are the I will say sequelae, problems, complications of connectedness. Here somebody may ask, is there any specific moro reflex in these babies with the connectedness? Because in cerebral palsy, suppose the baby is there, they may ask you. I think moro reflex is again very important in neonatology or neurology assessment. Therefore, any specific moro reflex with the bilirubin encephalopathy having any link association?
Dr. Dev has answered no Moro's reflex.
No moro reflex. Okay, so moro reflex is absent.
That's what I
Okay.
think he's meaning.
Yeah.
Exaggerated Moro's reflex from Dr. Kriti.
Okay. Dr. Preeti, I think Dr. Lata, you can try to locate. Who is Dr. Preeti?
Kriti, yeah.
Kruti, okay.
Yeah.
Why I'm answering very nicely. So I think she should contact me even, and everybody should contact me, all the students, because I'm ready to contribute something for them. Please remember here, is there any more responses before I answer?
Yes, sir. Same, sir. Exaggerated Moro's reflex. Different
Yeah.
kind with a cry. That was
Okay.
by
Yeah. Somebody is going to ask you the Moro reflex related to the connectors, so we should be aware of it. Moro reflex different types. Is the classical, which all the components, and which is going to be there in the full term baby after 28 weeks or so. Then there is the incomplete. What is the incomplete Moro? What is the complete Moro? What is the incomplete Moro? That means what are the components present normally in the Moro reflex? Somebody is going to ask you even to perform the test, demonstrate the Moro reflex in the exam. So you will take the head away from the cot for some about 30-45 degree and suddenly take away your head and see the response. But I think before the demonstration, let me make the point clear. Always before demonstration of Moro reflex, talk to the mother. Please,
Dr. Pradeep, please mute yourself.
Mute yourself. Moro reflex always, because the mother may not like it. And therefore always talk to the mother that I'm going to examine. It is a very simple examination. So baby may have some movements, but it is very simple. It is not going to cause any problem to the baby. So it is and if you talk, at least counsel the mother, take the permission, consent. I'm sure the examiner will, at least even if your Moro reflex demonstration is not right, then also he will pass. And as I said, afterwards, after aging, take your hand suddenly. So what happens? That there is first anybody? What are the components of Moro reflex? Very simple question.
So few have answered 3 components.
Yeah. 3 components, very good. What are the 3?
So they have written only open hand. I think they are answering to your questions. What will happen to Moros in bilirubin encephalopathy?
No. I think first, because now I want to complete the Moro because it is very common. I think probably I have not framed the question on the Moro, but very common, and already it reminded me. Once you leave it, what happens? There is the flexion, there is the abduction, extension, abduction, and opening the hand. Then there will be the embarrassing position, reverse. That is the very classical Moro. Incomplete, that means, it may not be the complete. That is the uplifting from this, that abduction may not be there. Adduction may not be there. Because the anti-gravity action is not developed. And that is usually in the preterm baby. So in the preterm baby, all the components may not be present. That is called the incomplete Moro. And what is the asymmetric Moro? So remember this, all the 4 different Moros. classical Moro,
occurs in brachial plexus injury.
incomplete Moro, asymmetric Moro. Yes, asymmetric, that means suppose right or left, where there is
Only
some,
one side present.
yes, one side it is seen, another side it is not seen, or may not be the appropriate with all the components. There may be in a case of neurological condition like any palsy, brachial plexus injury, Earth palsy, or sometimes there may be the fracture of even the femur or clavicle or something, and therefore that is the asymmetry. Exaggerated, what we say, or another thing, it is many people call it, Mermansi has mentioned, it is the reverse Moro. Actually, it is the exaggerated Moro. Somebody has very right answer. And that exaggerated Moro will be present in a case of bilirubin encephalopathy. So I think these are but I thought that it is going to be useful to you. Some examiner certainly is going to ask you. Which parts of the brain are specifically predilection for this condition? Please remember, it's a basal ganglia, particularly globus pallidus, subthalamic nuclei, hippocampus, substantia nigra, even oculomotor, vestibular, cochlear, and facial nerve nuclei. Therefore, these even the manifestation of nerves also you may get it. Reticular formation of pons, inferior olivary nucleus, even the anterior horn cell of spinal cord. So these are the components which are going to be affected. Anyway, let us take it further now. I think one more question on the jaundice probably. 72 hours old term baby presented with severe jaundice. Bilirubin is 32. He was born by a normal vaginal route to a pre-gravity mother, cried soon after birth. Birth weight was 2.9. Mother's group was O. There was some problem in establishing the breastfeeding. And on admission, baby is now brought to you after 72 hours. Weight is 2.5. Child was irritable, not accepting even the feed staff. This is a scenario. Now my questions. What is the problem with the baby?
The answers are already starting.
Yeah.
Breastfeeding jaundice, early septicemia, AVO incompatibility, bilirubin-induced neurological deficit, then breastfeeding jaundice due to insufficient feed, NNH, dehydration with hypernatremia, breastfeeding jaundice.
Very good. It's again, please remember, baby has irritable and not accepting oral feeds. Of course, etiology is this breastfeeding jaundice. And what are the risk factors for severe neural jaundice? Please remember, what are the risk factors? Jaundice in first 24 hours of life. You know why the jaundice is first 24 hours of life, it is dangerous? Or it is always pathological? Anybody, can you answer? Why the jaundice in first 24 hours is considered as pathological? I think everybody must be knowing, but why is it so?
Severe hemolysis, somebody has answered, Dr. Mohan Raj. Severe hemolysis.
Okay. If you see, I think in such patients, there is no much drop of hemoglobin. If really severe hemolysis, there will be a significant drop of hemoglobin. But hemoglobin is not, proportionate low.
The barrier is not mature, Dr. Arvind Sharma's answer.
Sorry?
Blood-brain barrier, I think his thinking. Barrier is not mature.
Answer is from?
Dr. Arvind Sharma.
Okay, Arvind Sharma. You know, that is the even not mature, it remains later on also. Second, third day it does not mature. Please remember, in the first 24 hours, whatever the jaundice is there, that is the direct time. Because indirect bilirubin is going to be taken away by the placenta. So most of the component in the first 24 hours is direct, and that indicates that significant jaundice. Of course, RH incompatibility. I think in RH, is it possible that both the parents are RH positive and baby is negative? Is it possible that both the parents are RH positive?
Responses have come, sir.
Baby is RH negative.
4 people have answered yes, and Dr. Raghavendra has said no.
Okay. I think both, yes or no is not the answer. We'll have to give the explanation. Both the parents are at RH positive, then how the baby is negative? If yes. If no, I think it's very simple, that it cannot happen. Anybody can answer? I think those who have answered yes must be knowing.
Please put on speaker and try to answer. It will be better.
Yeah, yes, please. You will remember, I think what is my idea, if I discuss such points, you will remember for lifetime.
Minor antigens they're answering. Minor
Okay.
group antigen. Having plus minus genotype. Rhesus DD, that means one capital D, one small d. Sperm over donors. Yeah, sorry, sir.
I can make out that somebody is knowing. Not everybody, but somebody else. Please remember that the positive, that means capital D, small d, or maybe even the capital D.
Yeah.
Right? That is the positive. Suppose from mother and child, father, both, if the child receives the small d, it can be the negative. So both the parents are positive and babies are at negative. That situation not so common, but yes, possible. But reverse, if I ask you, both the parents are negative, child can be positive. Both the parents are negative.
No, answer is coming. No.
Very good. In that situation, answer is no. So I'm sure that this is just RH incompatibility. Though so many things in the RH, we may not go in details. Just we want to go for further OSCE. G6 deficiency, yes, please, male child, jaundice, always confirm, and it causes the connectedness. Within the shortest time, bilirubin level increases. So if you are really doubt, please don't leave the patient. And of course, feeding problem, urinary infections, hematoma, yes. How will you manage this baby? Yes, with the jaundice. Yes, double volume exchange may be required. Then the choice of blood and everything. So many questions will come. Somebody will ask the question, what do you mean by the intensive phototherapy? Of course, IV fluid, and somebody has used even the intravenous immunoglobulin. It's a different story. Let me take to you some further questions. What are the 2 disease preventive measures routinely administered to all the newborns? Two measures which we are taking. That is for prevention of some diseases. And it is routine, in our routine practice. What are these 2 measures, preventive measures, preventive steps?
Hand washing, vaccination, vitamin K, hand washing, TD in mother, anti-D, exclusive breastfeeding. These are the answers.
Here 2 disease preventive measures routinely by the medical person. Naturally, the preventive measures by us.
Tetanus vaccination.
In OSCE, you have to answer very precisely. Hand washing, okay, you can say, but here it may not be considered correct answer. Most preventive measures which everyone we are taking is vitamin K and birth vaccines. Please remember, these are the question comes, then maybe the confusion to you. That's why I put that how you can address the question. Next question. Name 3 early disease detection measures. Please again read the question appropriately. 3 early disease detection measures which should be routinely done in all newborns before you discharge. Every baby, you should do this particular detection measures in all the newborns.
NBS, CCHD reflex, newborn screening, pulse oximeter, thyroid screening, pre-duct SpO2, red reflex, CCHD screen, TFT.
Many are included, but Here I will say my one request. Most of the people are good in the theory, but in the practice they don't translate. So please, answers are good, and here everything in every baby, please do this. Number one, transcutaneous bilirubinometer. For your safety, please do it. Because you have discharged the baby, next day comes with a connectorus, and suppose if you have not done mention this thing, that becomes a liability to us. SpO2, but I will say pulse oximeter screening. Anybody can describe that what you do in the pulse oximeter screening and how it is useful? What you do in the pulse oximeter screening, it is not just simply SpO2. How will you do? And then how will you interpret? And what does it suggest?
Dr. Madhavi has answered 4 limbs.
Okay. That is the most ideal, which is written in Gita, but we don't do.
Dr. Chaitanya has answered preductal and postductal SpO2. Check the pulse in all 4 limbs, right upper limb and lower limb.
Okay.
SpO2 difference beyond 24 hours. These are answers, preductal and postductal SpO2 to identify cyanotic heart disease.
But how will you interpret it? What difference?
SpO2 should be more than 95 in all 4 limbs.
That is normal. But you know, here,
Hyperoxia
if I give some clue, there is difference in upper limb and lower limb.
So 2 more answers have come, if you allow me.
Yeah.
Preductal and postductal SpO2 difference more than 5%. One person has answered, anonymous, and 1% has answered more than 3% in right upper limb and lower limb.
Right.
For
You know, please remember and please perform in your daily practice, pulse oximetry. Very easily handy. At least you're doing the right upper limb, and any lower limb. And if you measure all the 4 limbs, fantastic. But at least right upper limb and any lower limb. Difference is more than 5%. It indicates cyanotic CST. Please remember. And this should be routine to mention in your discharge card. Because you know what happens? You discharge the baby on the next day in the normal labor or so. And you know, ductus closure will take after 48, 72 hours. And ductus dependent cyanotic heart disease, the baby will get collapsed with a cyanosis and will brought to you on the 2nd or 3rd day. And even later on diagnosed as duct dependent cyanotic heart disease, baby may die. And if you have not done this pulse oximetry screening, we are in trouble. Nowadays, I will say gradually I have changed my teaching that not only the academics, but law is also very important. Safety in your daily practice. It may not be our intention, but here your ignorance, they will not consider. So pulse oximetry screening is very important. Metabolic disorder, blood screening, common 5 disease, most of the people are not doing. OA screen is very important. And particularly the high risk babies at least. But I think now routinely they say that in all the babies and TSH. So please remember these things, not only I will say for the exam point of view, but your daily neutral practice. That these things should be observed, not just observed. You know, some students are answering me the round that I measured the blood pressure, not written on the case paper. Nobody will listen to us. So all these points should be mentioned. Purposefully, I kept this OSCE, and this OSCE, exactly the same OSCE appeared in one of the exams in which I was examiner, and I picked up that this is a good OSCE for the one, not only for the exam, but practice also. Let us move further. I think, Lata, when the time is over, you can ask me. I think still some 10-15 minutes.
Yes, sir. Yes, sir. We have 15 minutes.
Okay. A unit was brought with complaints of the swelling of the left eye, and there was pus discharge. Look at the picture so that you can follow my questions. Yes.
We have already answered, sir. I don't know. Ophthalmia neonatorum, virulent conjunctivitis, ophthalmia neonatorum. So 4 persons have answered ophthalmia neonatorum.
Please don't say conjunctivitis. Here it is beyond, I would say something more than the conjunctivitis. Absolutely. It is the orbital cellulitis. Of course, ophthalmitis, if you say. But here I want something more. What are the common predisposing factors for orbital cellulitis? Some factor is playing the role.
Child birth trauma, instrumental delivery, vaginal discharge, maternal staph infection.
Usually, this is the eyelid infection. Older children may be the dental abscess. Very important, most of the times, even from the hematogenous spread, the part of sepsis. Local, I think 2 things in the newborn. Either the eyelid, even local infection can do, or even part of the hematogenous spread. Dental abscess for the older children. Common organism. Most common organism, I would say. Then you can say common organisms. Common maybe 2, 3, but most common maybe the 1.
Staph. They are answering staph aureus.
Yes.
Maternal staph infection.
Most common, but others can also play
Chlamydia.
the role. Chlamydia will not behave in this way. It will cause this conjunctivitis, not the cellulitis.
Streptococcus, somebody has answered.
Yes. This most common organism, staph, is the most common. Maybe the streptococcal and Klebsiella and others. But why I am asking the organism? So that you can answer the appropriate treatment, organism, bacteria, antibiotic. What is the treatment? Which antibiotics, specifically if I ask the question? Which antibiotic?
Amox, somebody has answered. And
Okay.
Vanco and Genta. Amoxiclav.
I think here, what is my idea? As a whole, I am talking. Always find out the targeted organism so that your choice of the antibiotic will be rational. Do you think any gram negative in this cellulitis? Therefore, what was my first question? Organism. If not gram negative, why the gentamicin? Of course, systemic infection, sepsis, if we are treating, ampicillin, gentamicin, ciprofloxacin, gentamicin, yes, aminoglycoside. But here, I think once you have defined the organism, I think Streptococcus, Klebsiella is not going to be treated by these aminoglycosides. Right. So, that is another thing which I want to sensitize you. Before deciding choice of antibiotic, ask these questions to yourself. What organism you are targeting? And whether for that organism, is it right antibiotic? If you ask the question in your daily practice, most of the times will be most rational. Here, most common, therefore, even I ask, what is the most common? So I will keep the most common first in my mind. That is staphylococcal. And therefore, anti-staph should be the antibiotic of choice. An anti-staph, which one? Ideally, the cloxacillin. But practice, I will say, routinely available, and if you are using amoxiclav, is not wrong. And really systemic infection or is a part of systemic infection, that can be even the MRSA. And therefore, vancomycin may be the answer. And really, abscess have taken place. Surgical intervention may be indicated. What complications are known? Please, why we are afraid of this. Don't send these patients at home with the oral antibiotic. Please remember another thing in antibiotic in the newborn. Newborn, if antibiotics are indicated by only intravenous route, there is no place to the oral antibiotic except some skin conditions which I will not consider. But antibiotic, if indicated in the newborn, that is by always intravenous route. And we are afraid of even from the orbital cellulitis for the life-threatening complications. So treat it efficiently because it can cause intracranial abscess, bacterial meningitis, cavernous sinus thrombosis, even panophthalmitis. I've seen the child where the enucleation of the eyeball was indicated from ophthalmitis. So I think this is very, very important. And therefore, the OSCE nowadays is one of the best methods of assessing the person. That you frame the question, select the most common scenario, and address the questions in such a way that person is able to address it appropriately. Let us go to the one more. A newborn presented with a painless lesion on the forearm, as shown in the picture. Look at the picture. I am giving few seconds, then I will go for the question. Okay. What is this lesion? What is the condition? Possible?
Aplasia has come as answered. Then warfarin.
Sorry?
Aplasia cutis.
Okay.
Then 3 persons have answered aplasia cutis.
Okay. Don't go for the complicated names. Go for the simple names. Greek, Latin, better to avoid. Very
No more
simple.
answers, sir.
That's why I ask you. Very simple. This is kept as a OSCE. Sucking blister. And this photograph I have taken from the OSCE. Actually, I have taken something wrong, but I have done the wrong thing to teach. This is a sucking blister. And the question is, what are the other sites where similar lesions may be found? Because I have seen that with this lesion, people will start the antibiotic or refer to the dermatologist. But this is very simple sucking blister. In utero, in the baby, in some positions, they are constantly sucking over this part and may be born with this type of the lesions.
The answers have come: finger, hand fingers, on
Yes.
probe attached site, limbs.
Very simple, where the baby should be able to reach.
Mm.
And therefore hands, forearm and lips. These are the most common sites. Of course, I think line of treatment, all of you know. No treatment. Again, explain the mother that why it has developed and it's a self-limiting and going to disappear within few days or in a short time. Another condition. A neonate developed the reticular mottling of the skin of extremities on day 4 of the line of the life as shown in the image. Please remember the baby was otherwise asymptomatic, active, taking the pills. On examination, everything is normal. But the skin lesions appear and disappear. And really it threatening to the parents. This baby was...
Answers have started. Sorry, sir.
Yes. Please. So let me go to the question.
They have already given answers, sir.
Very good, very good. Answer should come before the question, as in the KBC happens. Sometimes Amitabh say, let me complete the question. So what is the answer, Lata?
Cutis marmorata.
Very good.
Most of them have answered. One has answered hypothermia, cold atmosphere.
Right. Very good. It is neonatal cutis marmorata. Cause usually, yes, cold or even instability or, autonomous nervous system is not developed properly. That is another explanation. How the lesions get resolved, just we keep it warm. But suppose these lesions are seen in the older baby, not in the newborn. It is, I will say, in the toddlers. And it is not due to the cold weather also. And mothers say that it remains persistent. It does not disappear like this.
So most of the answers are sepsis, infection,
Baby
war,
is good.
atmosphere.
Baby is good, not any sepsis. Okay, I will frame the question in this way so that this will be discarded, that it is not due to the sepsis. If I give some important clue, it is due to some endocrine condition.
Hypothyroidism.
Hypothyroidism. You know, there is no cold in the environment, but yes, cold susceptibility is there. The hypothyroidism. And that for it is called as even again marmorita, but marmorita due to hypothyroidism. Okay, I thought that I have not kept it, but then the conditions similar to which persists in spite of remedial measures. Okay, that is cutaneous marmorita telangiectasia congenita. That will be newborn. If it persists, that is actually requires some then telangiectasia congenita. So if disappears, it is transient. It is the autonomous nervous system instability, but it remains constantly. Then think for this rare condition. Okay. A 10 days old unit was brought with the tender, hard, mobile, erythematous, violaceous nodule. You can see the picture on the lateral aspect of arm and back. In the winter season, particularly the month of December, January, calcium was not 7. This was the picture. Question. What is the likely condition? Again?
Already we have two answers, sir.
Okay.
Fat necrosis and erythema nodosum. Two people have said fat necrosis. One has answered erythema nodosum.
Okay. You know, they are giving me the questions. Therefore, in the exam, always I tell the students that the examiners don't come with the prepared questions. You are guiding them. You are forcing them. Now ask the questions to me. Now I will ask the question, what is erythema nodosum? Erythema nodosum is again in the older children. Most common sites are shin of the tibia. They are the discrete, painful, tender, violaceous lesions, yes. Most commonly it is due to tuberculosis and some rheumatological conditions. Erythema nodosum. It's a different entity, but yes, in differential diagnosis it comes. But it will not be present in newborn. Here we are talking of newborn. And therefore, correct answer is subcutaneous fat necrosis of newborn. What is the risk factor for this disorder? That means why it happens so? You know, what is the mechanism for development of the fat necrosis due to the cold?
IDM. One answer has come.
Sorry?
Infant of diabetic mother, I think, sir. IDM.
Okay. No, it is not due to diabetes. Not the, if it happens with the infant diabetic mother, I am not sure. I am not aware of it. But here I want the mechanism, explanation that why it happens so. Whatever may be the pathological, I will say pathophysiology, but how it happens. Please remember.
Trauma, pressure points, hypoxia. 3 more answers, sir.
Commonly we say trauma, but it is not due to trauma. Please remember, hypothermia is to some extent high, but how the hypothermia is playing the role. Absolutely. But you know, hypothermia develops to the many baby. All of them, they don't develop the fat necrosis. But hypothermia is the risk factor. Here, the brown fat of the neonate has increased the ratio of saturated palmitic acid to unsaturated oleic acid. And palmitic acid has a higher melting point than oleic acid. And therefore, it is susceptible to solidification and crystallization in response to the cold. That means it is due to the high level of palmitic acid. The ratio is getting changed. And if it comes with the hypothermia, it gets precipitated. This is the explanation. Please remember it is only the newborn with the brown fat. And what is the complication? Known complication in this disease? Subcutaneous fat necrosis. What does it cause? Some complication?
Hypocalcemia. Dr. Chaitanya has answered.
Okay.
That will be hypocalcemia. Calcium imbalance.
Anyway, they know. But please remember, not the hypercalcemia. And hypercalcemia is responsible for even this calcification of these tissues. And what is the course and prognosis? It is, if there is no further complication, self-limiting. Most of the time, self-limiting with favorable prognosis. But once it happens, everybody becomes the panic. Not only the parents, I will say, even the treating person. I have seen 2-3 patients. And then really till it disappears, we remain under stress that really, because it is become very solid and painful and tender, and then we feel that really what will happen, the outcome. But once you have seen 1 or 2 patients, you develop the confidence that, okay, ultimately it is not going to create any problem. So this is the really life-threatening condition. A 3-day-old baby was brought in the OPD with these skin lesions. The blisters were flaccid with erythematous base, and rupture lesions healed with yellowish crusting. You can see even here, if you can see these blisters, here it is in rupture, somehow healing I could not show you, and this is in the, I will say, just suprapubic region. My question is, what is your diagnosis? Another thing I will suggest for the teachers and for the students also. In OSCE, most of the times we will say what is the likely, what is the probable, what is the possible. The reason is, there can be the differential diagnosis also. But most likely you should answer, therefore probable. Yes?
Bullous lesion, neonatal pustular melanosis, aseptic pustule, pemphigus, bullous pemphigus, neonatal pemphigus.
Okay. Please remember, here it is very classical. Not even the pemphigus. They are even the similar lesions. Here, this is very classical bullous impetigo. Reason is, again in the practice it is common. This patient, if it is not, I will say, treated properly, after some time it will come to you with either the osteomyelitis or septic arthritis or pneumonia, staph pneumonia. Because newborns, these skin lesions will cause the invasive bacteremia. And that can cause either even the meningitis, pneumonia, osteomyelitis, septic arthritis. Suppose if you have even cause the trauma due to the IV line or something, then probably the child is vulnerable to develop the combination. Therefore, you should not miss it or don't take it lightly in the newborn. Bullous impetigo, and most common organism for bullous impetigo. Most common organism.
Streptococcus pyogen.
Very good. Bullous impetigo then is only one organism. Just impetigo, you can say even both, staphylococcal and strepto, but bullous means staph. Very special. Reason is, again, my approach is, if you say staph, then drug should be anti-staph. So what is the choice of the drug? Antibiotic? Which antibiotic you should go? Already we have discussed. Most, please remember, remember MSSA and MRSA. If it is community acquired, most of the time it is MSSA. But now MRSA is also increasing tremendously. And MSSA, if you are suspecting cloxacillin, is a good answer. Cefazolin is the next answer. And if you are suspecting MRSA, vancomycin is the answer. And for local application, yes, you can go for flupinoside. An 8-day-old neonate was brought in the OPD, with complaints of multiple these type of the blisters, pustular skin lesions over the trunk and limbs. The skin swab examination showed gram-positive cocaine cluster. Most probable diagnosis? Cluster.
Staph, scalded skin lesion, disease,
Okay.
SSS.
That will be, yes, you can put the differential diagnosis, but that SSS, Staphylococcus scarlet skin syndrome, will be generalized. It will not be in the form of the patch. And second thing, just by touching the skin, I will say get separated. Layer of the skin gets separated. Again, I think already we have got this bullous empirical streptococcal line of treatment already we have discussed. It is the repetition. So I'm not taking much time. I go for this. A full-term neonate presented on day 4 with this type of the rashes all over the body. Maximum over the face. Even this picture is over the trunk, back. But palms and soles are spared. No lesions. But these are the plenty of lesions. This is very common, I will say, in our daily postnatal round.
Erythema neonate.
Okay. So erythema toxicum neonatorum, what we name? Somehow there is no toxic, but name is misnomer, but it is there. Two varieties. It may be the erythematous, it may be the pustular. So these varieties we should know. But still, what cells you will be able to see lesions? Suppose if you go for scraping and examination, what type of the cells you will see here?
The eosinophils, 4 people have answered, one has said lymphocyte.
No, it is eosinophils. Please remember. But again, they say that it had nothing to do with much with the eosinophil, but they are same. And line of treatment? Line of treatment?
Self-limiting, nothing.
Yeah,
Reassurance.
very good. Reassurance. I think very few. So let me go a little bit fast and we can, at least whatever I have prepared, we can complete in 5 minutes, 5-10 minutes. I think 5 minutes it will be fine. A neonate presented with maculopapular rashes all over the body, more over the face, as it is seen in the picture. He also had blueberry muffin rashes and even the enlarged liver. Please look at the picture. This is real picture of the patient. And even it was confirmed diagnosis later on. Therefore, I thought that this will be the good ski to discuss. You can see the picture, not the question. What is the probable diagnosis with this scenario?
So the answer has already come. Meningococcal congenital CMV, neonatal CMV, torch infection, congenital rubella syndrome, and rubella.
Very good.
These are the answers.
Please, I think meningococcal is not the presenting in this. That to newborn. It's a congenital infection, and all the infections what it enumerated. Differential, yes, maybe the congenital toxoplasmosis rubella CMV. They are right. And what are the features? All of you know, with the jaundice, pallor, organomegaly. Eye examination is very important in such patients. Even hydrocephalus, microcephaly is very important. Toxoplasm will cause hydrocephalus. Others can cause even the microcephaly. Cataract can be seen in rubella. Chorioretinitis can be seen in CMV. So all these points are very, very important. What history you would like to elicit from the mother? That fever or skin rashes in the first trimester, sometimes when the MMR vaccine, or paid particularly for the cat or toxoplasmosis, and investigations, all of you know. I may not go in the details of investigations. A 1.5-month-old infant was brought with the following scalp lesions. You can see the picture. And the question, what is probable diagnosis? What is the scalp lesion?
The answers already come. Cradle cap, seborrheic dermatitis.
Right. Yes, I think answer is there. Seborrheic dermatitis of the scalp, as crab cadle, many people say, right?
Yeah.
Which structure of the skin is involved in this disease? As we said, sebaceous gland, like that, which structure of the skin is involved in this disease?
Sweat glands. Dermis.
Again, sebaceous glands. What is the morphological description of this lesion? I think it is very commonly parents are complaining to this. It is not uncommon in our daily practice. These infants, particularly 2-3 months old children, they bring with this type of skin lesions over the scalp. And they are, if you see, they are erythematous, grazy scales, and even crust formation. And difficult to name sometimes the organism, they say. Melasma furfur. Important, I will say, applications. These are the petrolatum, ketoconazole, even tar-containing shampoos, even hydrocortisone 1% steroids. Commonly, we are prescribing steroids. Plus, my question is, suppose the similar skin lesion, but in older children, and even with that hepatosplenomegaly and lymphadenopathy. Many times I have seen, that's why I have kept the question, that they consider seborrheic dermatitis even in the children. You know, they are older, even hepatosplenomegaly, lymphadenopathy.
LCH.
Very good. That is the Langerhans cell histiocytosis. It is said that seborrheic dermatitis, and I have got this patient from dermatology OPD, that they have treated for some time for this seborrheic dermatitis. And somebody will see that liver spleen or lymphadenopathy, because usually they don't examine for this. And then they will refer. And then we'll go for the workup, and turns out to be Langerhans cell histiocyte, not uncommon. Please remember. I think very few questions. Now, last few slides. Answer the following. You know, they are asking in the form of some questions also pertaining to some topic. As I said, enteral steroid, they will say neonatal jaundice. Sometimes they will say cyanosis. Sometimes they will put even in the form of some other maturity or even the weight point of view, some definitions. So I think in that way you can prepare. What is the breastfeeding jaundice? And I think already somebody had answered previously. So just to save the time, we know that it is due to the inadequate feeding. There is the loss of weight, even maybe the dehydration, and there is increased enterohepatic circulation, and the jaundice is there. So this is very classical. That means it is due to the feeding problem. But what is the breast milk jaundice? It is something different entity. Here some substance is responsible. That is 3-alpha-20-beta pregnant diol. It is a metabolite substance which is present in the breast milk, and some lipase and fatty acids. They interfere with the conjugation of the bilirubin and results in persistent prolonged physiological jaundice. Otherwise, baby is absolutely normal. Usually, that we should suspect after 2 to 3 weeks. Very classical. But my question, should we stop the breastfeeding? No, please don't stop the breastfeeding. Anyway, next, some of the, I think, rapid fire, like you can answer true or false. Physical examination is not a reliable measure for serum bilirubin level. True or false, right or wrong?
Yes, false, yes.
Please, I want to convey the exact message. On the contrary, I am insisting that I will be more relying on my clinical examination. But here, no. Whatever you feel the jaundice, compared to that, bilirubin level may be different. So that's the point which and specifically suppose phototherapy is going on, never rely upon this your skin examination or something. That's a message which I wanted to convey. Another, when clinically jaundice is evident in the newborn, serum bilirubin is more than 5 milligram or 2 milligram. This 5 milligram is right or wrong?
Three persons have said true.
Hmm.
One is no, then true, wrong. So 4 persons true, 2 persons wrong. Mixed opinion, sir.
So I think I have framed the question rightly, Lata. Am I right?
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
So
Definitely.
as I examiner, I think it's a good question. It's true, in the newborn, if you feel, if you are convinced that bilirubin jaundice is there clinically, always bilirubin is more than 5. And for, I will say, clinical appearance of jaundice in older children, bilirubin is usually more than 2. And to say the raised bilirubin, which may not be evident, but serum bilirubin, more than 1.2 is abnormal. So serum bilirubin 1.2 is abnormal. Clinically, jaundice in the older children, that means bilirubin is always more than 2. But in the newborn, if you feel it is jaundice, bilirubin is always more than 5. And jaundice in the first 24 hours is always physiological.
False. No, it's pathological.
Already we discussed, always pathological. Don't wait. Breastfeeding is contraindicated in breast milk jaundice.
False. No,
Then my question, what are the contraindications for breast milk jaundice? Real contraindications. Real contraindications.
Galactosemia.
Galactosemia, correct.
TB. TB is under contraindication.
Anything else?
HIV in foreign nations.
Sorry?
HIV in foreign nations.
No, it's not contraindication. That you will have to counsel, whatever you want to give. On the contrary, in our country, we give this breast milk. You can give the, I will say, choice to the parents. Don't go for the mixed feeding in short in the HIV. That's the message. In a contraindication is the galactosemia. Second, if the mother is on anti-malignant drugs or anti-thyroid drugs, then you will have to stop the breast milk. Anyway, so just to complete, ABO group incompatibility occurs when mother is A or B. No, it is the mother should be O and baby should be A and B. Name the probable clinical diagnosis in a given scenario. Probably this should be the last slide. Dextroposition of heart, respiratory distress and scaphoid abdomen. Newborn has presented with this.
PDH.
Heart sound on the right side. Yes. Please answer completely. Congenital diaphragm hernia on the left side.
Yeah.
Bilious vomiting and scaphoid abdomen. Bilious vomiting and scaphoid abdomen.
IHPS.
Sorry?
IHPS.
What do you mean by it? I'm not sure.
It's a hypertrophic pulmonary stenosis. Idiopathic hypertrophic pulmonary stenosis.
No, there is no, on the contrary, no
I think
bilious
so.
vomiting.
Yeah.
Hypertrophic pulmonary stenosis, non-bilious vomiting. And that will not be the scaphoid abdomen. On the contrary, there will be the swelling. So that's why I say that read the question properly. Both the things will be absent in the hypertrophic pulmonary stenosis. Hypertrophic pulmonary stenosis, after giving the feeding, there will be the swelling appearing. Even moving swelling from left to right, after vomiting, swelling disappears. And never the bilious vomiting. Bilious vomiting and scaphoid abdomen in duodenal atresia.
Atresia. Yes, few answers have come, sir.
Okay, fine.
2% have answered.
One more question. Bilious vomiting, blood in the stool and scaphoid abdomen. Please remember this condition. It is going to be helpful in the practice also. Bilious vomiting, blood in the stool and scaphoid abdomen. Anybody?
Still waiting, sir. Well, Meckel's diverticulum.
No, Meckel's diverticulum will not be having the bilious vomiting. Meckel's diverticulum having the bleeding per rectum. And
band.
Profuse bleeding per rectum and painless bleeding. That is the characteristic.
Yes, sir.
But here,
ileal band, somebody's answer.
rather than the band, volvulus of intestine.
Mm.
One more. Frothing from mouth and scaphoid abdomen. Very simple. Frothing from mouth.
Mention which types of tricus, TEF they have answered.
Yeah, esophageal
I think they should
atresia.
answer. But types they should tell, sir.
Yeah.
That is more important.
What is the warm chain in neonatology? Cold chain, warm chain, reverse warm, even the cold chain. These are the questions people may ask. Warm chain, all of us know, please remember. And why am the question? I will say question is not important, just to remind you to insist, because very simple measures will prevent lot many complications. Warm delivery room, warm resuscitation, immediate drying the baby, skin to skin contact, breastfeeding, bathing postpartum, appropriate clothing, particularly covering the head. Sorry, that spelling is wrong. Mother and baby together, professional alertness, and warm transportation. If you have to remove, I will say transport the baby. And here, I think I should end. Thank you very much. I thought that few OSCEs were there, so let me finish. Thank you very much. I hope that purpose is served. Initially, I have kept the very simple common conditions. Next time, we can take the more complex conditions in neonatology, so that probably we can, and I'm sure that these OSCEs are not just for the passing the exam, certainly for passing the exam, but even afterwards, even in the daily practice, quite useful. Thank you very much. I know that we have overshooted the time. Please consider. I ask for the really apology for that, and
No
over
need.
to you.
No,
Dr.
sir, no, sir.
No,
Not
no,
Excellent.
required.
I learned a lot.
It's very informative.
Yeah.
And
Sir, I learned a lot. Thank you so
Sir
much.
Srinivasan, sir, you are really, please, I think
No, I learned a
all the
lot.
students may not be knowing, but Srinivasan, sir, is retired professor, I think around 85.
No. I am a student and learned
He
a
is from
lot
the
from you
Jipner
today.
Pondicherry. And please remember, since last 5 years, my Tuesday clinic hardly sir has missed. I will say that dedication. So I mention over here for the, I will say, inspiration to all of us, particularly the students. And every time, even sometimes, suppose if it's not, he will ask me the message that is it recorded is available. And that I will, therefore, and really this is the best learning for all of us.
You are the best teacher, so committed and so patient, and I have been fortunate to be associated with you so many
Thank you,
times.
sir. Thank you. Very
Thank
nice of you. So now, Lata, over to you, and I will say all the office bearers. On the contrary, I should thank all the office bearers. They are giving me this opportunity, and this is, I will say, my first interest is to learn, and whatever naturally I know, I can share with the students and to all the friends. Thank you very much.
Thank you, sir, for such a wonderful OSCE once again. I'd like to thank everyone everyone present here, and I think we have Nehal, madam.
Yes. Thank you so much, Lata, for being there constantly with sir, helping sir with all the answers for whichever the student writes into the chat box and delivering it to the sir very promptly. Thank you so much, sir. You are the heart of Gurukul, sir. So we are thank you for that. We are really very much thank you for that. All the students are thankful to you. Thank you so much, sir, for being there. Thank you, all the students. Please join again next time. It's a case for
Good
the
night, all of you.
neonatology
Yeah, thank you
case
so much.
discussion. Yeah, thank you all.
Srinivasan sir, namaskar and good night.
Hello, sir. Hello, Yogesh. Thank you. I have to thank Yogesh.
Yes,
Yeah.
Dr.
because,
Yogesh is there.
Yeah,
Dr. Yogesh is there. Dr.
Sir, I have been a
Yogesh
regular student of Dr.
I know, sir.
Prajapati.
You are witnessing since last 5 years.
Right from his Tuesday classes, I never missed.
Thank you.
Okay, bye, sir.
Thank
Bye.
you, all of you, and good night.
Good night.
Good night.
This
Good
really the team efforts that we are, and as Dr. Nehal said, probably now for Lata it is a compulsion because I am asking that is there any response,
Yes.
so she has to remain there.
Yes, sir, it's my pleasure,
Yogesh
sir.
bhai,
Really, it's my
namaskar.
pleasure.
Namaskar, sir. Namaskar.
Yeah, namaskar, sir.
Okay.
Thank
all
you.
of
Good night, all.
Good night. Good night.
Good night. Good night.
This is